So in thinking about the development of this particular protocol, as most of you know, there's a significant amount of overlap among what we would call DSM or ISD disorders, particularly anxiety and mood disorders. But also, if you extend some of the basic pieces out toward eating disorders, somatization disorders, many of them have a strong emotional component to them. Certainly anxiety is an important component of psychosomatic difficulties. We see a high degree of comorbidity, as you know, across these different disorders. If you are depressed, there's a very high likelihood that if you are not currently anxious, at some point in your life you will be meeting clinical threshold for an anxiety disorder of any kind, as well as vice versa. We also, at least in the previous iterations of the Diagnostic and Statistical Manual, had these not otherwise specified disorders, not otherwise specified subthreshold disorders for individuals who didn't quite fit into our nicely described categorical system here, that unfortunately over time has become more and more narrowly focused, even though that might be inconsistent with the data showing that things tend to be a bit more dimensional, which is one of the reasons for the development of transdiagnostic interventions in general. Certainly the UP is just one of many different transdiagnostic treatments. It is a relatively recent phenomenon. We're talking about the last decade or so in CBT anyway, but it isn't the only one, and I should clarify that. But because of that high comorbidity and that increasingly narrow slicing, of defining different problems and creating very specific manualized treatments to address very specific problems, there's a disconnect with the clinical reality. And it makes it quite difficult for us to train and implement good psychotherapies when we are so focused on these narrowly defined categories and narrowly defined interventions. When you look at basic psychopathology research, going back actually many decades, you find different research groups and pathways coming to a very similar conclusion that actually there are these higher order dimensions or underlying factors that seem to cut across these different emotional disorders, in particular anxiety and depression. These underlying factors that seem to account for what we call the covariance among these disorder constructs, however we might define them, and how they operate longitudinally over time, within treatment, but also just their natural course over time. So what are some of these higher order dimensions? Most of you are familiar with these dimensions, I'm sure. It goes all the way back to neuroticism, Hans Eysenck. And our understanding of neuroticism really is built around this predisposition to experience heightened levels of negative affectivity. Okay? Experience negative affect more intensely, more frequently. But the other piece of neuroticism, there's sort of a two-part definition of neuroticism, at least the way that we've been thinking about it, which is that predisposition to react more strongly. And certainly it has a broad genetic basis to it because we're talking about temperaments here. But also this tendency to react quite strongly and negatively to that negative emotion if it's evoked. Okay? And we'll get more to that in a few moments, right? So you experience more negative affect and your reaction is quite severe to that experience of negative affect. You're more sensitive to it, you could say. Other ways of basically saying the same thing, over the decades. You have Gray's model of behavioral inhibition, behavioral activation, so negative affect, positive affect. Kagan's work with young children, his developmental studies looking at social anxiety and behavioral inhibition early on, predicting social anxiety down the road pretty consistently. Telegen, Clark, Watson, they have their model of negative affect and positive affect, showing that if you look at depressive disorders, anxiety disorders, they all tend to be relatively high on this negative affect structure that does map on quite well to this neuroticism construct that's been around for quite some time. And so based on more recent work and all the work that's been done up to this point, Tim Brown's done quite a bit of research looking at very large samples in treatment, outside of treatment, tracking some of these core constructs and these DSM disorder constructs, such as what we would call major depression or generalized anxiety disorder, and actually tracking them over time. And using structural equation models to try to parse out what some of the common variants might be. And that's where we get these factors like negative affect, positive affect. These dimensions tend to differentiate between these different disorder constructs pretty nicely. But of course, really the prevailing element is this heightened negative affectivity. With positive affect, you do seem to find a bit more variation across the specific problem areas. You know, when we think about positive affect, unless we're talking about mania, which you could argue is the one example where you have a destructive sort of increased capacity for positive affect, right, that is not useful. We usually think about depression being low in positive affect, right? So individuals have a predisposition to sort of, it's difficult for them to experience positive affect or experience non-contingent sort of reinforcement in the environment, you know, due to that lack of a basic emotional, I guess, foundation or temperament to allow that learning to take place. Interestingly, social anxiety tends to also link quite highly onto low positive affect. It seems like depression and social anxiety are the two major disorders that are explained by low levels of positive affectivity. And you get more mixed results in other anxiety disorders. It's a little bit more mixed. People used to assume that in generalized anxiety disorder, excessive worry, that actually low positive affect, because they're sort of stuck in this negative state, ruminative worry state, that individuals with GAD, because they tend to be cynical, relatively pessimistic, they must have low levels of positive affect. The research seems to show that's not necessarily the case. They're not necessarily low, at least when you compare it to people who are depressed or people who are socially anxious. It doesn't mean that they're happy all the time. More often they're not actually all that happy, but it doesn't seem to characterize that disorder as well as it does maybe some of the other disorders. So this is some of the work parsing out these underlying dimensions or temperaments. And this might be too small to see. I just wanted to put this up here because this is an example of one of the, this is actually taken from the an earlier study. I believe this is the 98 study, but there's a similar replication was conducted in 2007 with very similar results, where you run these structural equation models and you have these two higher order factors of positive affect and negative affect. In this particular study, and again, we can distribute slides. You don't have to worry about getting it all at this point, but I wanted to put it up here where you can see that your positive affect, you have that load onto depression, but then you also have that load onto social phobia or social anxiety, and it's not as strongly loaded onto some of these other disorders. But by measuring these disorder constructs and these temperament constructs over time, we can begin to get a better sense of what some of these underlying dimensions might be. And I think ultimately our goal, although we think it's quite a ways off, is to actually develop a profile based on these factors, almost like an MMPI, you know, where individuals have an emotion avoidance and a negative affectivity, positive affectivity profile, and that you're targeting your interventions based on this profile, based on an initial assessment and more data, rather than targeting the specific disorder in a way that's consistent with some of the UP strategies that we'll be talking about. A little bit more about development and some of the basic background, just to show that when we're talking about the development of any one particular disorder, social anxiety, depression, generalized anxiety disorder, even though there are some of these temperamental differences, when you actually look at some of the gene research, it's not very compelling in terms of being able to isolate or identify a particular gene that would account for the development of or a vulnerability to experience OCD, for example. You know, certainly there is a genetic basis to it, but it's polygenetic. There isn't a specific gene that leads one to become phobic of dogs, you know, for example. Okay, so we are talking about a broad-based vulnerability. Okay, So the research seems consistent with that, which is another sort of element or another pathway toward, well, if this is a broad-based vulnerability, then the manifestation of these different problems is potentially useful, but if we're actually talking about targeting the core of some of these difficulties, then maybe we want to pay more attention to the implications of these more broad-based vulnerabilities, such as negative affectivity. Research has also shown that we tend to develop these generalized psychological vulnerabilities that are not specific to any particular disorder, not any specific anxiety disorder or depressive disorder. That early disruptive experiences, and these do not have to be particular traumas like we might think about in terms of post-traumatic stress disorder. These can be just general disruptive sort of attachment experiences, for example, tend to lead to or are part of this experience of the world as being lack of control, having a lack of control in the world being an unpredictable place. Okay. So there's this lack of controllability that becomes learned, that is easily developed once you also have these other risk factors in terms of temperament, as you can imagine. And you have these experiences growing up, and learning continues to take place and things get reinforced because now we have this particular model that we're viewing the world with. And the consequence is not one specific disorder. Individuals who manifest these vulnerabilities, individuals who say, for example, Kagan research with the behavioral inhibition, it's not just social anxiety that they will eventually develop, it's generalized anxiety, it's major depression. Okay. So this represents a generalized psychological vulnerability, which again means that even though there are these specific manifestations, certain people are afraid of heights, certain people are afraid of germs. What is really important may be more of what cuts across those different problem areas. Maybe it's this generalized psychological vulnerability. Research by the neuroscientist Sapolsky, who's at Stanford. Many of you may know his work. He spent many years living amongst the baboons. Looking at stress and corticotrophin releasing factors and showing that within the hierarchy in baboon culture, and it's a very hierarchical, individuals who are at the bottom of that social hierarchy tend to experience this hypercorticalism that leads to hippocampal degeneration. And you see them manifesting all of these behaviors that are actually quite consistent with anxiety and depression. And the implication is that it is linked with this level of uncontrollability or unpredictability, always being on the defensive, always being hypervigilant, hyper-aroused. The unfortunate piece for this, for any individual, not just a baboon, is that it does lead to this hippocampal degeneration, which has a host leads to a host of different problems for us in the long term. For one thing, it makes it very difficult to learn. And so when we're talking about new learning in psychotherapy or new learning from exposure, this actually puts somebody at a disadvantage to be able to benefit. So we want to be able to target some of that. But again, this stress response is to no outlets for frustration, lack of prediction, chronic threats, social subordinates. These things are also not necessarily specific to one particular disorder. This lack of controllability, you see different elements of that and that stress response, that hypercorticalism across the disorders. So we tend to think about this as synergistic vulnerabilities. And if you think about the basic nature of the different disorders and their components, we have this biological vulnerability that we talked about a bit, sort of that temperament, that generalized psychological vulnerability. And once you introduce stress, it could be a trauma, it could be recurrent stress in the environment. That stress often can lead to a false alarm, something like a panic response. So you start to develop strong physical symptoms or hyperarousal, hypervigilance in situations. And then over time, as these physical symptoms increase and interoceptive conditioning takes place and the stress continues and you have these sort of foundational vulnerabilities, the idea is that eventually you develop this more generalized neurotic style. Okay. So GAD we're thinking about as really the prototypical neurotic disorder. That this is kind of the potentially the most difficult to treat because it is the most purely sort of neurotic in some ways. And at least our idea is, and there's much more research that would need to be done, is that if you were able to slow things down really, really, really slowly in a way that is not practical, but theoretically, if you were able to slow things down, this would be the gateway to social anxiety and depression and these other specific disorders, that this process occurs initially. And actually, Alloy and Chorpita and Barlow, they've done research to provide some support for this, that when you look at depression and you look at the nature of depression in terms of hopelessness, helplessness, and sort of the nature of what happens with GAD and anxiety in terms of lack of control, how persistent lack of controllability and reinforcement and in the context of increased stress leads eventually to that hopelessness, helplessness, right? Because you can't do anything to change your environment or situation. And so that can lead to depression, and that's very consistent with some of the work that Alloy's been doing. So there's depression. I work with adults mostly. By the time they come to me, they have all of the above. So even if you have this broad-based vulnerability, of course, not everybody develops a disorder of any kind. Some people turn out just fine. They don't experience many problems. But if you are high on neuroticism and you are in a context where you're experiencing consistent stress or experience a traumatic event or a stressful event, then we all know, right, that the tendency is to engage in responses that are going to help us manage our experience and regulate our experience. We do the best we can in the moment. And so individuals who are really upset experience high levels of negative affect, experience uncontrollability, do what we naturally do to try to enhance controllability and downregulate. Okay. And so very early on, you start to see these, what we would call avoidance behaviors or defensive strategies to help maintain consistency and help maintain that emotion regulation. And as that continues and those behaviors continue, then many of these difficulties just become stronger and at the very least are maintained and may even generalize. Avoidance generalizes to other avoidance strategies, and then the more restricted one's life becomes, you tend to, if you just let it go, you tend to find more restriction. So this is a model that was developed by Campbell Sills talking about persistence of emotional distress and acceptability of emotions. And so if I have a predisposition to experience high levels of negative affect, I experience my high level of negative affect. I'm high on neuroticism, for example, low on positive affect. I'm inhibited. And I have the sense that this emotion is intolerable or unacceptable. It might be intolerable just because it's physically intense and I don't like it. It might be unacceptable because we've learned that it's unacceptable. That we've learned that it's unacceptable to have a strong emotion. We need to be sort of serious and logical and not act out and be in control of ourselves. Or that you shouldn't complain if you're feeling a particular way. Or you should always be happy. Like there's something wrong with you if you're sad. You should always be happy. So you've learned this notion somewhat naturally, maybe also relationally, and then you engage in efforts to suppress, and the suppression will ultimately fail. In the short term, it may decrease negative arousal, but there is that negative reinforcement. And this is really, when we talk about suppression, we talk about suppression as a less adaptive emotion regulation strategy, because it's not responsive to what's important about that emotion in that moment. So we react in a way that's inconsistent with what the emotion is actually oftentimes trying to tell us to do, trying to help us attend to certain information, help us modify our behavior in a particular way. So we lose that. We get caught up in just the negative arousal. We try to suppress. We don't benefit from the initial emotional response. Suppression gives us short-term relief, but eventually it comes back. And often it's even stronger. We'll talk a little bit more about suppression tomorrow, but many of you are probably aware of the studies that have been conducted on white bears and the worry suppression studies. Tom Borkovic did a series of studies on worry and GAD, instructing certain people to worry during a task and certain people not to worry during a task. And you actually find that if you suppress the worry during the task, people will report being much more distressed when they leave the lab, and then 3 days later, they're still much more distressed than they were when they entered the lab. So that's the long-term effect of suppression. However, if we accept the emotion for what it is, and we don't necessarily have this belief or expectation that we can't tolerate it, we don't engage in suppression, we let the emotion run its course, it usually recovers naturally, and we are able to engage in a response that's more adaptive. This is the good side. Okay. So all of this is to say that these diverse symptoms, the different behaviors that we see, the quote-unquote symptoms that are reported by individuals with different problems, they serve a similar function. And to a large degree, that function is that emotion regulation or emotion avoidance. So less adaptive emotion regulation. Controlling one's experience, and that is experience broadly defined, its thoughts, feelings, behaviors, the environment. So when we talk about disordered emotions, we really are talking about, as Gross talks about, when he talks about emotion regulation, dysregulation, is that we're talking about the occurrence of a particular emotion, its frequency and its intensity. So a disordered emotion, is happening when it shouldn't happen. So something that we would call an overlearned emotional response, where somebody is actually offering care, but somebody responds with anger because they've learned that an offer of care will be met with punishment. Okay. That's an emotion happening in response to the environment in that moment, but its occurrence doesn't make sense given the context. Okay. That usually if we are trying to show care, we would expect that someone would feel relieved or happy or glad or at least more relaxed to receive that care. Okay. Intensity, certainly the intensity, and when we talked about predisposition to experience negative affect, its frequency and also its level, more intense. And it's happening often. It's happening many more times than we would expect it to happen, a particular emotion might. So they're anxious most of the time. So the conceptualization is that many of these difficulties that we've defined in various ways that are accounted for by these underlying factors represent a problem of emotion regulation. And what we want to target are these aversive reactions to these emotions, very broadly speaking. Okay. We want to target the efforts to control, avoid, and suppress experience, both by targeting situational avoidance, which we'll talk more about, cognitive avoidance, and subtle behavioral avoidance. And by engaging in these behaviors, these less adaptive regulation strategies, negative reinforcement wins out every time. That's what maintains the difficulties. And when individuals avoid, as we all know, they don't give themselves the potential to, or put themselves in the situation to have the opportunity to experience new learning. And we talk about expectancy violation. This is partly why these difficulties get maintained. If we avoid going up on the elevator, if we avoid having a discussion with a friend who we feel like we've wronged or something and we're feeling very shameful or guilty, then we never put ourselves in a position to actually test out that our negative expectancy is going to happen or not going to happen. So we don't have that. We don't give ourselves those opportunities to learn, which is also the strong maintaining factor. So this meaning, these expectations continue to be embedded and strengthened within this more dysregulated emotional framework. Okay. So that's the conceptualization. Now let's think about the current state, or what we would consider to be the current state of the literature or the treatment literature. We know that we have a number of effective treatments, and these are effective treatments across a number of different orientations. Research seems to show about 8 to 10% of all individuals in psychotherapy actually do not respond or even deteriorate. And even in controlled trials, we find percentages upwards of 40% of individuals who do not respond to the state-of-the-art treatment. We can do much better. As I mentioned before, at least at the current point in time, we have too many distinct protocols addressing ever-narrowing problem areas. And actually, if you look at many of the different, particularly CBT manuals, the differences are relatively trivial in terms of the different strategies that are being used. They use a different word for the same thing. You know, we're all talking about cognitive reappraisal or something at one level. They have a slightly different worksheet with a different picture of a, of a person on it. You know, the person's wearing a shirt instead of, a sweater. Like there are very slight differences across these manuals. So there should be a way for us to bring these together. And the protocols are still relatively complex, and the fact that there are so many of them, and the fact that they're complex, and the fact that everybody wants to be evidence-based, so they need to be trained up on these protocols, this makes it very difficult, right? So really, for some time now, the state of the field has been calling for, or where we were in the field, there was really, it was time to start to think more concretely about developing strategies or set of strategies that can be more easily learned and implemented quite broadly, and to people of varying orientations and also varying training levels. So this was all, I guess, prologue to the development of the unified protocol. Distills and incorporates common principles of what we would call evidence-based cognitive behavioral therapies and emotion science. So I would say what is different about the unified protocol compared to some other transdiagnostic approaches is that I would not characterize the UP as eclectic. Okay? And what I mean by eclectic is it's not a mix of specific interventions that have an evidence base, and whatever CBT intervention has evidence behind it, let's bring it in. Like everybody, more the merrier. Let's just bring all these interventions in. If it works, let's do it. It certainly is flexible enough to bring in new treatment elements, but eclecticism does not, at least by the textbook definition, involve an underlying theory. Eclecticism is empirically driven. Empirically and patient-centered, I guess, in some ways, that this particular intervention for this person at this time. And so I do a whole bunch of things. The UP is a little bit more trans-theoretical and what I would call assimilative, in the sense that the underlying theory is what I just described, that it really is embedded in emotion science. And emotion science, new learning, some of the exposure elements that Mats and Eric talked about this morning, that's where all these different treatment elements and modules come together. That represents the foundation for this. So I do think that is what makes the UP slightly unique as a transdiagnostic treatment. It isn't simply, we're going to do cognitive therapy, we're going to do exposure, we're going to do monitoring, and then put those together. And that is transdiagnostic, but hopefully you will see that there is more of an underlying structure that holds it all together. And some of these core elements are objective emotion awareness. Talk about emotion labeling, becoming more aware and objective about how one observes, reflects on their experience and also the experience of other people. Reevaluating cognitive appraisals and expectancies. So we talk a lot about increasing flexibility, cognitive flexibility. So it's maybe a little bit different from the traditional cognitive restructuring that's done. Reduce emotion avoidance, and there are a number of strategies to help reduce emotion avoidance. Modify less adaptive emotion-driven action tendencies. This is when we talk about alternative behaviors. Okay? We'll talk more about each of these things because these are all linked with the different modules. Okay? So modify current behaviors that are less adaptive. That includes avoidance behaviors, but it also includes behaviors that are engaged in response to the intensity of the emotion itself. And then the big focus is really on exposure and creating opportunities for new learning, what we would call a corrective learning experience. And hopefully you'll see throughout is that in thinking about how we're defining exposure and the elements of what makes a good exposure, what leads to inhibitory learning, for people who engage in a lot of suppression and are emotionally avoidant to the point of being even though I don't love this construct, alexithymia, people know alexithymia. I don't love the construct, but certain people are even so, they can't even, they can't identify the emotion. And really, emotion regulation starts with being able to identify and differentiate the emotion, right? And some people can't even do that. Okay, that was whirlwind. It was a whirlwind tour. So I'll stop there, and then I guess after lunch we'll come back to the actual modules.